Very good evening, everyone. Today will be a short topic regarding obstetric pharmacology. So we will start off with a basic overview, simple anatomy and physiology regarding the uterus muscles and vessels. Then we go on to the uterine contraction physiology. Then we'll discuss the SAQ related to that. Then for the next few slides, I'll talk about the uteroplacental circulation, the transfer, the concept behind that, and then SAQ regarding to that. Okay. Okay, let's start. Okay, uterus, this is the basic anatomy of it. The thing that I want to show you all here is these two parts that we are interested, the myometrium and the endometrium. Okay, so everything else, the other things you all know about it. So the myometrium is the contraction part, endometrium is the inner lining of the uterine cavity. So what I want to show you is, if you want to look at the uterine wall, muscle wall, so you have a perimetrium, which is the outer wall, then we followed by the myometrium. The myometrium contains smooth muscles. Okay, these are the smooth muscles, which also have a blood supply, which goes into endometrium as well. So you can see the blood vessels in the myometrium are linear. We call it as arcuate, then followed by a spiral arteries in the endometrium, and finally the uterine cavity. The smooth muscle cells in the innermost layer of your myometrium. Okay, these are smooth muscles. So the uterine muscle contraction is based on the smooth muscle contraction, relaxed state, and contracted state. So basic physiology about uterine smooth muscle contraction. So you just follow here. Okay, the numbers. Number one, there will be a calcium influx and calcium release from the sarcoplasmic reticulum when there is a action potential arrive or there is a input for smooth muscle contraction. Then the calcium will bind with a protein called calmodulin, CAM, this calmodulin, calcium calmodulin complex. This calcium calmodulin complex will activate, okay, the myosin light chain kinase. Okay, this activated myosin light chain kinase will phosphorylate myosin 8. It's an active process. So myosin light chain kinase phosphorylates the light chains of myosin 8 using myosin ATPase activity. Then these active myosin cross bridges slide along the actin and create muscle tension and to contract the cells. So this is the sliding filament theory. Okay, calcium induced calcium release. This is the calcium induced calcium release. Calcium is being influx, then also causes release of calcium on the sarcoplasmic reticulum, then binding to calmodulin. Calmodulin activates the myosin light chain kinase, an enzyme. That enzyme causes phosphorylation of the light chain of myosin 8 using myosin ATPase activity, and that linkage will cross bridge, will slide the along the actin and causes the muscle contraction, sliding filament theory. Okay, and for us relaxation, once the contraction finishes, some events occur in reverse to relax the cell. Basically, the calcium concentration reduces, calcium efflux, and calcium moves intracellularly to sarcoplasmic reticulum. So decrease in calcium concentration. So the calcium calmodulin complex being broken down, then there is a dephosphorylation of this myosin, and then the muscle contraction ceases. That's in brief. So about the uterine vessels, uterus is being supplied by two arteries. One is ovarian artery, and then another one is uterine artery, and minimal input from the vaginal artery supplying the cervix. So if you look at it again, please concentrate on the myometrium and endometrium. The ovarian artery and uterine, they form the arcuate artery. Arcuate artery form the radial artery, which is in the myometrium, and the radial artery becomes a spiral artery in the endometrium. So why I want to show you this before going into the topic. So we talked about the muscle, and we talked about how the vessels are going through the muscles from the perimetrium to myometrium to endometrium. So when the muscle contract, they will constrict these vessels, so there won't be any bleeding or there won't be any blood circulation. Whereas when the muscle relax, these vessels vasodilate, so there will be a uteroplacental circulation or uterine circulation, or there will be in terms of, you're talking about uterine atony, there will be a bleed. Okay, so that is what we want. So what is uterine atony? We just look at it. We talked about the muscle, ovarian artery and uterine artery supplying. So in uterine cavity, this is endometrium, this is your myometrium. Contraction of uterine muscle compressing vessels and prevent bleeding. In uterine atony, when there is lack of uterine muscle tone, means the uterus unable to contract, lack of uterine contraction can cause acute bleeding because blood vessels are not compressed. So during the delivery of the baby, after the baby is delivered, if the uterus fail to contract, where in such a state called uterine atony, the blood vessels are not compressed, so that can cause the massive bleeding. Okay, so in which we have to give, there are four factors, main factors, like we remember the mnemonic T, that which can cause uterine atony. I'm not going into the depth of it, just for the remember. One is the tone, the uterine muscle tone itself, it is lost. And then actually there are 4 T's of postpartum hemorrhage, and number one in the T is the uterine atony, like the tone. The other T's which leading to postpartum hemorrhage will be trauma, thrombin, and tissue problem. Okay, retained product or conception. So what I want to talk to you about is this uterine atony, and how do we treat this uterine atony, which is the number one cause for postpartum hemorrhage. So we talked about uterine stimulants, which are uterotonics, means the drugs that causes stimulate the contraction of the uterine muscles, or the tocolytics are drugs or agents that relaxes the uterine muscles. Okay, so uterine stimulants called uterotonic increase the tone of muscles. They induce muscle contraction, smooth muscle contraction, used for induce or facilitate labor, reduce postpartum hemorrhage, or induce abortion in case of miscarriage. Whereas in uterine relaxants are tocolytic. Toco means childbirth, lytic means terminate. It means it prevents the uterine muscle to contract, inhibit. It's basically used for stopping premature labor. So next, we go into the SAQ. Again, my concept of talking about best answer versus practical answer. So what I'm going to show you is almost near to best answer, but practical, which can be easily reproduced. Once again, my advice would be, this is just a guide. Please do your own reading and make your own template of your answer. This is just a guide to help you all. Okay, so the first two questions talking about classify uterotonic drugs with mechanism of action and classify tocolytic drug with adverse effects. If you look into the past year, the questions are lingering around the same thing. It will be uterotonic drug or tocolytic drug. First will be classification, followed by either the mechanism of action or adverse effect for both. Okay, uterotonic mechanism of action or adverse effect, or tocolytic mechanism of action or adverse effect. There are only certain drugs, so it's all a fact. You have to know it for sure. Okay, so this is the examiner report. So I've highlighted the important things. So they've said classify. They need to classify for uterotonic, classify into few different classes. They're talking about oxytocin group, ergometrin group, and prostaglandin analogs, and mechanism of action. Each drug needs to be elaborated. It means they want you to tell in detail in cellular mechanism. Whereas for tocolytic, again, classify into beta-2 agonist, calcium channel blocker, and cyclooxygen NSAIDs, and magnesium sulfate, nitrates, and volatile anesthetic. And score high marks were able to describe in detail the type of receptors involved and intracellular mechanism. See, you need to explain in detail. Okay, so this is how I classify. Okay, these are the drugs that you must know regarding uterotonics and tocolytic. Uterotonic is oxytocin or carbetocin. Carbetocin is your duratocin. Okay, the one that use duratocin, the long-acting single dose. Next is ergometrin. Okay, the combination of these oxytocin and ergometrin is your symptometrin. So I didn't put it up here because it's a combination of two drugs. Okay, oxytocin plus ergometrin in a specified dose is called symptometrin. Next, analogs such as carboprol, which is F2 alpha, PGF2 alpha, or PGE1 and E2 will be misoprostol and dinoprol. We use carboprol for postpartum hemorrhage, but we use misoprostol for induced abortion, okay, in early parts of pregnancy. Okay, next we have tocolytics. Tocolytics are called your carboprol, your dinoprol is your that you use for, that you put intravaginally to induce labor. Okay, so this is your Curvagen, we induce labor at term, misoprostol to induce abortion at early pregnancy. Tocolytics are drugs that stop the uterine muscle contraction to prevent premature labor. Beta-2 agonists, we have terbutaline and ritodrine, and we have calcium channel blocker, nifedipine, or the drug namely Adalat. Atosiban is an oxytocin antagonist. It's a direct antagonist of the oxytocin receptor. And then we have NSAID, which is indomethacin, used also for premature labor. Why did I put it in purple? Indomethacin is quite special. It has some specific adverse effects that we have to know of. Okay. Next, I'm going to talk about few drugs which have the properties of causing uterine muscle wall contraction and uterine muscle wall relaxation, but they are not used as for therapeutic use. It means these drugs which we use day to day, daily, or in anesthesia practice do have these properties, but they are not used for that reason. Okay, first for uterotonic, ketamine has some uterotonic property. It means it can cause uterine muscle wall contraction, acetylcholine as well, noradrenaline, because we talked about the uterine muscle wall as smooth muscle, and smooth muscle can respond to alpha-1 receptor. Alpha-1 receptor, noradrenaline can cause vasoconstriction or also cause smooth muscle contraction, and serotonin and bradykinin as well can cause uterine muscle wall contraction. This is for MCQ or SBA purpose. Whereas tocolytics, we have volatile anesthetic. All volatile anesthetic causes uterine muscle wall relaxation. That is why when we're doing a seizure under general anesthesia, we are worried about going MAC more than 1 for sevoflurane, because MAC more than 1 for sevoflurane can cause uterine atony. Except nitrous oxide. Nitrous oxide does not cause tocolytic. It's more towards uterotonic because of its different mechanism of action. Okay. So nitrous oxide does not have tocolytic, and then GTN and magnesium sulfate, all these have tocolytic property, but these drugs are not used as therapeutic to cause tocolytic as for premature labor. They do have the property, but not. So what you have to remember is this table. Okay, for exam, this table. If you see the examiner report, they do mention volatile anesthetic, GTN, magnesium sulfate. You can put a word, but I won't. This is not actually a therapeutic use as a tocolytic. Okay, hope you understand. Next. Okay, I've got this table from, I think, Ketamine Nightmare. They have nicely put it up here. So I've just taken, it's a very nice table explaining the oxytocin mechanism of action, all the uterotonic mechanism of action, and adverse effect. I understand our question only asked about utero classification and mechanism of action, but I put it the adverse effect here as well, as it's given in Ketamine Nightmare. It's easier. In case the question asks about adverse effect, you have the answer here as well. So you have to at least talk about 3 drugs in detail: oxytocin, ergomotrine, and PGF, prostaglandin analog. For prostaglandin analog, if you cannot recall which one is PGE1, which one PGF2 alpha, it's okay. You just mention prostaglandin analog, give example misoprostol or carboprost, it's okay, no problem. Regarding oxytocin, we have to mention it binds to oxytocin receptor. Oxytocin receptor is G protein coupled receptor, subtype GQ. So I'm not going to go into the depth of it. You know how the GQ protein coupled receptor works. It works for IP3 and DAG, increasing the calcium concentration and causing the smooth muscle contraction. You have to make a note, oxytocin at low dose causes intermittent contraction. That's what we do in our, to induce labor, okay, in induced labor. At high dose, it causes tonic contraction, which you give intraoperatively once the baby is delivered. Okay, we want to cause a continuous contraction to prevent uterine atony. Whereas during induction of labor, we give kind of low dose to cause intermittent contraction. Okay, so you have to remember this. Oxytocin at high dose can cause hyperstimulation syndrome, which can cause fetal asphyxia. So you have to understand that as well. Adverse effect, it can cause nausea and vomiting by causing contraction, increase the blood pressure, so can cause nausea and vomiting. It sometimes can cause vasodilation, causing blood hypotension as well. It has a slight ADH effect. Same goes to, it is oxytocin as a ADH analog. So it can cause an effect on kidney, causing fluid overload because it causes water reabsorption and hyponatremia. Okay, it can mimic the action of antidiuretic hormone, which can cause water reabsorption and hyponatremia. So ADH effect can cause fluid overload in renal or cardiac failure patient, or you must be very careful in a patient who have preeclampsia or eclampsia patient. That is why we give oxytocin in small doses in a patient who have preeclampsia or eclampsia or pregnancy-induced hypertension patient. As I mentioned, high dose can cause hyperstimulation syndrome, reducing the blood flow, causing fetal asphyxia. It has a side effect of causing lactation as well. Okay, so you have to remember this part. Carbetocin is a similar and synthetic analog oxytocin, which is a duratocin. Ergometrin, the oxytocin exact mechanism are unclear, but they are agonists at alpha-1, 5-HT and D receptor. Alpha-1 causes smooth muscle contraction, so that's how they most probably cause the uterotonic action. They cause tonic contraction at any dose, okay? Whereas oxytocin, low dose, it's intermittent, high dose tonic, whereas ergometrin, it just causes tonic contraction, means continuous contraction. That's why it's used intraoperatively. Known receptor effect, alpha-1, it causes vasoconstriction, so increases systemic oxygen, increase BP, increase APO. That's why it is contraindicated in a patient with hypertension or patient with preeclampsia. Before you give symptometrin, which is a combination of oxytocin and ergometrin, you have to ask patient whether they got any hypertensive crisis or any heart problem before you giving it. Then there's a 5-HT2 agonist can cause nausea, vomiting, and dopamine agonist, which can cause nausea, vomiting as well. One of the reasons the pure ergometrin has not been used currently in obstetrics. Yeah, so that's why we use the symptometrin, which is a combination of oxytocin and ergometrin, which has a balanced side effect of these two. They doesn't cause much of a side effect rather than giving the direct one drug. This is a combination as a better pharmacokinetic and pharmacodynamic profile. Next, we talk about prostaglandin analog. So prostaglandin analog, simple. They bind to prostaglandin and they work through multiple G protein coupled receptor, especially GQ, similar action to oxytocin. So prostaglandin also work via G protein coupled receptor, mainly the GQ, causing the same effect as oxytocin. The one thing you have to remember, misoprostol can cause diarrhea. And another important thing, which is PGF2 alpha, which is carboprost. For carboprost, intraoperatively, we have to ask the patient whether the patient has asthma or not. It can cause bronchospasm. So you have to ask patient got asthma or not. Main thing, it can cause bronchospasm. Okay, remember, for ergometrin or symptometrin, you have to ask patient got any hypertensive issues or heart problem. Whereas for PGF2 alpha, which is carboprost, for carboprost, you have to ask patient got asthma. Okay, so this is important things you have to remember. So this is from Life in the Fast Lane, where they have given even more detail. This is not answering exam. This is for notes purpose, where they have talked about oxytocin, ergometrin, dinoprost, which is herbagem, and your carboprost, which is PGF2 alpha. So again, they have mentioned everything. You can see respiratory for carboprost and dinoprost, prostaglandin can cause bronchospasm. So this is important. Okay, so you have to remember that. So this I'll share these slides with you. This is for your own notes thing here. Okay, next we move on to tocolytics. Again, the answer given in ketamine nightmares very nicely in table form, talking about mechanism of action of adverse effect. We talk about beta-2 agonists such as terbutaline or ritodrine. As the group name suggests, it's a beta-2 agonist. Beta receptors works via GS. GS means they're going to increase your cyclic AMP. What does cyclic AMP do in smooth muscle contraction? They inhibit the myosin light chain kinase, so there is no muscle contraction. We have talked about the smooth muscle wall contraction physiology. The contraction involves myosin light chain kinase activation, whereas cyclic AMP inhibits the myosin light chain kinase, so there is no actin and myosin sliding and so on. So the adverse effect, you all can name the beta-2 agonist side effect. You should know this. The heart rate, the tachycardia, the lactic acidosis, tremor, so on and so on. Next, we go to calcium channel blocker. As the name suggests, it inhibits the L-type calcium channel. So there is a reduction in intracellular calcium. So there is no increase in calcium. There is the flow of the calcium-induced calcium release and also the calcium calmodulin complex, all that are inhibited. What it can cause reflex tachycardia because of vasodilatation and peripheral edema. Next, we talk about atosiban first. Don't mention about GTN. Go to atosiban first. So number one, you're going to talk about beta-2 agonist. Next, you talk about calcium channel blocker. Third, you're going to talk about atosiban. Atosiban is a competitive antagonist at the oxytocin receptor. So it just opposite of oxytocin, which causes uterine contraction. The adverse effect is headache and nausea and vomiting. All these are good used in premature labor. And we're going to talk about NSAID, which is endomethacin COX inhibitor. What they do, your COX enzyme is important to produce prostaglandin, which causes muscle contraction. When you use NSAID, which is a COX inhibitor, it's going to inhibit the prostaglandin synthesis, leading to uterine relaxation. What I want you to talk about endomethacin, the adverse effect, the common NSAID related, the bleeding, the ulcer and whatever. But the important part you must remember is endomethacin can cause PDA closure, patent ductus arteriosus closure. In fetus, the patent ductus arteriosus is important for fetal circulation and oxygenation. Please go and read about it. So giving endomethacin in quite early, prematurely can cause this PDA closure and cause problem in fetus oxygenation. So please go and read about how does endomethacin related to this PDA closure. Endomethacin is therapeutically used to close the PDA once the baby is born. In a patient, in a child who would have a patent ductus arteriosus who fails to close, we give NSAID or endomethacin or ibuprofen sometimes to close the PDA once the baby is born. But before baby, prematurely, if it close the PDA, it can cause problem to the fetus. Next, as I mentioned, GTN and volatile anesthetic, they are not therapeutically used as tocolytic, but they have properties of as a tocolysis. So I'm not going to go in depth of it. Okay, so these are the 1, 2, 3, 4 that you have to mention. Okay, that's about uterotonics and tocolytic. Now we move on to uteroplacental flow. Okay, so please pay attention. So we have maternal circulation, we have fetal circulation. Fetus is solely depending on mother for their oxygenation, for their carbon dioxide removal, for their waste removal, to receive the nutrients, and also as an immunological function. So your placenta have multiple function. I hope you all have read the PDF that I gave. It's very nicely written and very clearly explained with examples. Okay, placenta have multiple function. One is the metabolic transfer, endocrine function, and immunological function. So first we talk about blood flow. I've already mentioned to you, uterus is supplied by uterine artery and uterine vein, the venous drainage. So we talk about uterine artery. So the uterus have uterine artery as a blood flow which carries the oxygenated blood. Okay, the oxygenated blood goes to myometrium to supply the uterus, and it also goes to the intervillous space. What is intervillous space? Intervillous space, it is an exchange space. It's a place with highly vascularized. It is a space between your placenta, which has placenta in between, which is sandwiched by maternal circulation and fetal circulation. That is the place for the transfer occurs. So intervillous space. So this is your placental membrane, which is sandwiched one side by the maternal circulation, another one is the fetal circulation. So the uterine artery will carry the oxygenated blood, and it will get exchanged at the placental membrane and carried by umbilical vein. In fetus, the oxygenated blood are carried by umbilical vein, not umbilical artery. Okay, we have single umbilical vein and 2 umbilical artery. Okay, please remember that. So from the uterine artery, exchange occurs at the intervillous space across the placenta, then goes into umbilical vein. And once it goes to umbilical vein, from the fetal circulation, the deoxygenated blood and the toxic material, everything come via 2 umbilical artery and comes into the same area where the transfer occurs and exchange here, and then it carried into the maternal circulation via uterine vein. So please remember, in maternal, oxygenated blood, uterine artery. In fetal, oxygenated artery is a single umbilical vein. In fetus, deoxygenated blood is by umbilical artery, 2 umbilical arteries. Then it goes into uterine vein in maternal circulation. Again, look at this picture. Uterine artery bringing in oxygenated blood and goes into umbilical vein. Umbilical arteries carrying the deoxygenated blood and goes into uterine and ovarian vein. So please remember and understand this. Do not get confused. Next, we go to placental transfer. So the same thing in a thematic view to talk about the transfer. Again, uterine artery, umbilical vein, umbilical artery, uterine vein, the maternal circulation and fetal circulation. So the transfer occurs. So what is being transferred from maternal to baby is oxygen, nutrient, drugs, and metabolites. whereas from the baby, carbon dioxide, urea, and waste. So this is how it occurs. You should be able to picturize this. You should be either able to do it in this form, or you should be able to do a schematic diagram like this for you to remember. You have the placental barrier from the fetal side, which is being sandwiched in between the maternal circulation and fetal circulation. Okay, so everything from the mother to baby or baby to mother has to go through the placenta. Okay, understand this. Okay, so we talked about placental transfer. So what are the methods or what are the type of transport that occurs through this placenta from the mother to baby or baby to mother? So the number one important is passive diffusion, okay, which follow the fixed law of diffusion, because your placental membrane being same like any other cell membrane, they are like lipid bilayer, and it follows all the similar properties of a normal cell membrane and the transport across it. Okay, so number one and the most important is the passive diffusion, which accounts for 80% of the transfer from the maternal to fetal or fetal to maternal circulation. Next, we have transporter mediated. Either it can be facilitated transport, exchange transport, or active transport. And finally, minimally via endocytosis using or pino or phagocytosis. Okay, so remember this. You have to be able to mention this. Okay, this part I'm not going into the depth. It's about the placental oxygen balance. This picture is from Carey Brandeis. Please go and read this section on Carey Brandeis. They have explained very well about this using this picture as the reference, and they have talked about your Bohr effect and double Bohr effect. Everything is there. So again, you have uterine artery from where it goes into your umbilical vein. Okay, the oxygenated blood. Whereas from the uterine vein, it comes back to, from the umbilical artery, it goes to uterine vein. You can see the uterine artery have higher PO2, 100 millimeter mercury, umbilical vein have 28 millimeter mercury. That's why it can easily diffuse across the concentration gradient along the placenta. Whereas umbilical artery has higher PCO2, whereas uterine vein have a lower carbon dioxide partial pressure, so it can also diffuse across easily. The CO2 here is not carbon dioxide. This is the content of oxygen. Okay, arterial oxygen content. C is content, not CO2. Don't get it wrong. Okay, it's talking about oxygen content. Okay, I'm not going into the depth. So this is all talking about the diffusion distance is very small, 3.5 micrometer. We know according to Fick's law, the diffusion distance is inversely proportional to diffusion rate. So the placenta have a very large surface area, which is good for diffusion. It is lipophilic, so it can carry multiple lipid drugs across the lipid bilayer, and they have a very small diffusion distance. All these are favorable towards the diffusion across the placenta. So please go and read about it. Next, again, this another picture which shows full detail about what are the partial pressure of oxygen content, PCO2 content, the pH and everything. You can see this is your maternal side, this is your fetal side. You can see the maternal side is more alkalotic, fetal side is more acidosis, and you have to know about the P50, okay? The P50 about your fetal circulation and maternal circulation. Fetal circulation have a low P50. It means they can steal the oxygen from the maternal circulation. So then that's where your Bohr effect and Haldane effect, all this comes into picture. The acidotic part, how does it cause the shift of the curve to the right and left and everything. So please go and I will share this info and use this as a reference to read up as well. Okay. Okay, next we go to the SAQ related to this. Again, the practical answer. So how does pregnancy at term influence the pharmacokinetic anesthetic drug? Okay, of course, I did discuss about the changes, the physiological changes occurs in pregnancy at term. Please go and read about it. I'm going into the question directly. I didn't discuss that part. Okay, next we're going to talk about what factors influence the rate of transfer of drugs across the placenta. This one we have discussed, the anatomy and physiology. Next we will discuss the factors. So this is the examiner's report. Whenever we talk about pharmacokinetic, you cannot run away talking about absorption, distribution, metabolism, excretion. So your answer in that template, ADME. So you need to know what is the physiological changes at term for a pregnant patient, and then how does it affect this ADME. And then the question mentioned clearly of anesthetic drug. So you have to talk about anesthetic drug. They say some candidate gave wrong example mentioning non-anesthetic drug. So you are not answering the question. So you have to talk about ADME. They have give few things here. Then also worth noting, some candidate gave example of such as warfarin and phenytoin. So you're talking about drugs that is not used in pregnancy somehow. So that won't get you any marks. Next, part B, they ask you to talk about placental transfer. You have to talk about fixed law of diffusion, and then you have to explain how that variables in that equation assist in the placental diffusion. Okay, so I have made this template myself. So I've got the information from few references, from Matthew Ho, ketamine, and also from the notes that I have. So I made it in such a way that it's quite easy. I know it looks like a lot of information, but the question is 4 marks only. So first, you have to divide it into ADME, and you try to give at least 1 or 2 points for each section. Okay, at least 2 points for A, 2 points for D, 2 points for M, 2 points for E. So you make your own template. Okay. So absorption in term pregnant patient, the gastric mortality means there'll be delayed gastric emptying time. That is why we worry of aspiration also. Why? Because of the gravid uterus compressed stomach, also progesterone effect causing relaxation. What is so longer the drug stays in your stomach, increase absorption of oral drug. Then it's talking about the respiratory changes in which reduce FT and increase minute volume, also secondary to progesterone, which is causes increase in speed of onset of inhalational agent because it increases the FA-FI. And it also, the progesterone effect is the reason why a pregnant patient needs only a lower MAC to achieve the same pharmacodynamic effect. Next, we talk about increase in cardiac output. So increase in cardiac output causes increased circulating volume, peripheral vasodilatation. So what it does, it causes, there is absorption of the drug given transdermal. So again, based on the fixed law of diffusion, when you have an increase in circulating volume, you maintain the concentration gradient, so increased speed of onset. IV drug, there will be a reduced one-arm brain circulation, so increased speed of induction. The drug can be carried from your injection site to your brain faster, so it can cause a faster onset of action. In terms of central neuroctal blockade, epidural vein size is being increased. So when there is size increase, the volume remains. Relatively, the volume become lesser. So this is because of the blood vessel engorgement. So we only need a lower dose of LA to cause the same pharmacodynamic effect. That is why we worry so much about giving spinal in pregnant patient. We will always calculate the dose. We not like in a normal non-pregnant patient, we just give a normal dose without worrying about the spinal effect. And then we talk about distribution. The total blood volume is total body weight is increased also because of the plasma volume increase at term. So it means the volume of distribution is increased. So all the drugs you have to give a higher loading dose. There'll be an increase in albumin or plasma protein, mainly because of dilutional effect. Albumin significantly dropped from 40 to 25 gram liter at term. So it means there'll be a more free fraction of drug, which is not bind to albumin. So less dose required in that kind of drug. I am not giving examples here. Okay, the examples you have, I ask you to read PDF. I want you to do the homework. Competition with non-esterified drugs, okay, then increase in body fat contributes to increase in volume of distribution for polar substrate, sequestration of lipid-soluble drugs such as thiopentone and amiodarone, then fetal distribution because we have to include the placental circulation, lipophilic small drug penetrate the placental membrane, increases the VD to include fetal circulation. This is prolonged by ion trapping, so that when we talk about ion trapping, we're going to talk about local anesthetic here. Okay, next, metabolism, the cardiac output of the maternal circulation increase, so hepatic blood flow increase, so there will be an increase in liver clearance of drugs which has high hepatic extraction ratio. HER stands for hepatic extraction ratio. The enzymes activity is increased because of the enzyme induction by the progesterone effect. So it increases the metabolism of highly dependent drugs that highly depend on liver metabolism. Reduction in cholinesterase activity, no effect for succinylmetonium because it is counter-effected by increase in volume of distribution. But for ester local anesthetic, we don't use ester local anesthetic, we use MI. But in terms of ester local anesthetic, their metabolism is reduced. Finally, we're going to elimination. Again, because of increase in plasma volume and increase in cardiac output, GFR increased clearance of renally excreted drugs, and increase in minute volume because of progesterone effect, increased washout of volatile anesthetic. Same thing, fast in, fast out in pregnant patients. Okay, because increase in minute volume, increase in reduction in FRC. So this is my answer for that. what I want you to do is read up on your own, read up the PDF that I gave you, and you will include the anesthetic drugs here. Okay, you will include the anesthetic drugs here as an example. That is your homework. Okay. Again, next we are going into the factors that affect the placental transfer. 4 mechanism. So main 3 mechanism: passive diffusion, transporter mediated. Transporter mediated can be facilitated or active, and finally is endocytosis, either phago or pinocytosis. Okay. So these are the summary of factors affecting drug transfer across placenta. This is from the PDF that I shared. They're talking divided into physical and pharmacological. But our answer, we're not going to answer like this. This is for notes, okay? Because if you look at the SAQ, what factors influence the rate of transfer of drugs across the placenta? They gave you 4 marks. So they need some kind of explanation. They didn't just mention list, okay? So this is just listing out, okay? But we need to explain a bit more. If you look at the examiner report also, they said they need a bit of explanation, especially on fixed law of diffusion. So for the physical property of the placenta, as I said you, the large surface area, small thickness, which is the diffusion distance is small, pH of maternal fetal blood. So this is where the concept of ion trapping comes into play. Your placental metabolism, uteroplacental blood flow. If more blood flow, maintain the concentration gradient, increases the transfer. Presence of placental drug transporter, which can assist in carrying drugs which needs a facilitated transport or active transport. Pharmacological is based on the drugs that we use, the pharmacological property of the drug itself, which can assist in easy transfer. Molecular weight of the drug, smaller molecular weight, easy transfer, again fixed law. Lipid solubility, highly lipid, easily can cross across the lipid layer of the placenta. pKa, more unionized, can easily cross. Protein binding, free fraction of drug, unbound drug, easily can cross. Of course, higher concentration gradient in maternal versus fetus, easy transfer, or also from fetus to maternal, especially for toxics. Okay. So factors affecting maternal to fetal drug transfer, we're going to talk about increased transfer, molecular weight less than 1000 Dalton, uncharged molecule. It means molecules are less charged. pH versus drug pKa, higher proportion of unionized drugs. Okay. And then if there is a placental efflux, we're talking about efflux mean what we're going to send out. We're going to increase transfer mean present. It means, so don't pay much attention to this efflux transporter. Just remember, if there is a transport protein can assist, it can increase the transfer. Binding protein type in a patient in maternal circulation, as I mentioned, albumin is lower. It means more unbound drugs, so it can easily can transfer. Okay. So next, so we come to the way I answer the question. So we're going to briefly mention method of drug transfer, and we're going to explain according to that. So we already talked method of drug transfer. First, the most important is a simple diffusion, which is described by fixed law. So you have to mention this equation. Okay, you have to mention this equation, and then you're going to explain one by one, as I mentioned. The solubility, you're going to compare the carbon dioxide and oxygen. Please read the PDF. They have mentioned about this again. The area, I've mentioned about the large placental surface area. The concentration gradient, higher the concentration gradient between maternal and fetal, easy transfer. Molecular weight, talk about the drug. Especially you have neuromuscular blocking agent, which are bigger and charged molecules who cannot cross compared to smaller molecules such as your other drugs, such as your opioid. And your thickness, we are talking about small diffusion distance of your placenta. I'm not going explanation. You have to do it on your own, and that's your work. Then facilitated diffusion requires carrier protein. More carrier protein present, it can cross. Active diffusion or active transport needed carrier protein, which uses energy. So what you want to mention here, it can be saturated at high concentration, and competition may occur for the active transport protein. Finally, pinocytosis for large molecules in calcium-dependent proteins such as globulin and proteins. Again, this is just the outline. You're going to make your own template based on that. Okay, but the scheme or template is going to be like this. So drugs in anesthesia, Matthew Ho, he has summarized this. He has talked about the common drugs in anesthesia. How do they cross placenta? Opioid, mostly a simple diffusion, being lipid soluble, only 50% protein bind, poorly soluble, weakly protein bound to cross membrane, so unbound, so it can cross. LA cross the placenta via simple diffusion because they have low molecular weight, high lipid solubility, and low ionization. But once it goes into the fetal circulation, because fetal circulation is more acidotic, that's where they can get ionized and causes the ion trapping concept. Okay, so remember this part. Volatile, they have low molecular weight, they're lipid soluble, easily can cross the fetus. So diffusion hypoxia can occur. IV induction agent, again, they're highly lipid soluble, so they can cross. Neuromuscular blocking agent, they cannot cross the placenta because they're highly ionized, polylipid soluble. So they generally do not cross the placenta. Actually, all the common drugs used in anesthesia can cross placenta except neuromuscular, the blocking agent. Sedative, your benzodiazepine can cross. Anticholinergic, again, is the same concept as your blood-brain barrier. You have a tertiary and quaternary amine. Your tertiary amine can cross. Your tertiary quaternary amine, which is glycopyrrolate, cannot cross. So that's all about today's topic. Thank you.